I'm having a hard time, I guess, understanding how the medications make it to the room where the patient is when they arrive in the hospital. Is this when you pull out that wooden stick in the old ways of doing things, when you pulled out that wooden stick and you landed on a medication dose that was appropriate, are there just bags of these different solutions mixed up all ready to go in the room? Or what's the process for getting the proper medication administered to the patient? And we've got to remember, this is a patient that's coding usually, and time is of
the essence, right? Yeah.
Yeah. You know what? I wish that you and the audience could see the videos in the code room, but I'll try to describe it for you. And there's always, that one room in the emergency department that's different from all the other rooms. It's where all the sickest people go. Either you're in cardiac arrest, you're coding, or you're septic, you're having a seizure. It's where you go when we don't have time to go put orders in the computer, let the pharmacist verify it, send down the medication, have the nurse scan the barcode. Like, none of that is happening in this room. So what they've done is they put in that room a cart, okay, the code cart. And the code cart has a number of drawers. And the very top of that drawer are basically the primary medications that you would use during a resuscitation. So they're kind of sitting there in vials. Oftentimes kids need an infusion, and those infusions usually have to be made. In other words, they don't come really ready-made. You have to make them up. And once you make that infusion, then you have to figure out, well, how fast does that infusion have to go into a 1-year-old, 3-year-old, 5-year-old? But you have these medications sitting there in the room, not all of them, just the first line, if you will. At the head of the bed, and I'm evaluating the patient, and I verbally will call out for medications. And so if I just say I need epinephrine, 100 times out of 100, someone's going to say, well, what dose? And then they follow that up with, well, what volume is that? And that's where they kind of made this long tape. And in this particular case, they have to hand it to you. But when you're at the head of the bed and you're trying to run the code and manage everybody, and mom and dad are typically, I bring them in right next to me, that's not what you want your doctor to be doing. You want your doctor to be saying, here's what I need. And someone says, I'm getting it for you. I need a chest tube. Let's intubate. Let's get epi, amiodarone. Let's do a norepi drip. And it happens that quickly, you need people to say right back to you, I'm getting it. Now, if that medication is in that top drawer, they'll pull it out, but now they need a volume. So what happens is now there's an interchange between physician and nurse while the kid is dying, because the nurse doesn't have that math, because the math was never done for anybody. So you find yourself now in a conversation that you shouldn't be having. You should be focusing on the kid and the rest of the room. So what ends up happening when you see people who are not good at resuscitation, or their room is not set up the right way, or they don't have a product like Handtevy, the tensions start to mount and they start to build, and people's voices start getting louder, and the parents start getting more nervous, and they're pacing, and you see people running in and out of the room. So if you saw a video of the code room with no voice, just on mute, you could tell in 2 seconds whether they have their stuff together or not. And the folks who don't have their stuff together, people start doing things just because they don't want to be the one that everyone's looking at. And it becomes very busy and very moving. And sometimes kids have an error of commission. That was the error that I made, one of the errors I made, where I gave 10 times more. But maybe more important and maybe more frequent are the errors of omission, which means that you know that a kid needs a drug, but they don't get it because no one knows how to get there. I made that mistake, unfortunately, where I knew a kid needed an infusion to get her blood pressure up, but I knew that mom and dad were right next to me. If I would have said, I need a norepi drip, the nurses would have said, what dose? How do you want to run it? How do we mix it? I didn't know any of that, and neither did they. So they had to call Steve in pharmacy. And, unfortunately, Steve didn't get me the medication for 20 to 30 minutes. By that time, I was already up in the ICU with this girl who still has a very low blood pressure, and her level of consciousness was deteriorating. And unfortunately, that girl didn't make it. And she ended up passing a couple of days later. Now, could I have told myself that this girl was very sick and it wouldn't have mattered. You could tell yourself, but I know that I didn't do justice to her. And I didn't do good by her or her family. And so your initial question was, how does this all go down? I now have the privilege of going to hospitals around this country, and I see exactly how it goes. And you can go to the best hospitals in this country, the best, and you can drop a 3-year-old in cardiac arrest. And if they're not prepared and they don't have all the dosing pre-planned and they haven't been coached, it's like you dropped a grenade in the room. So no one is immune from this, unfortunately. But to your point earlier, the fact that this is even a question is still so interesting of a topic for me to talk about here in 2025.